Hi, everyone. Thank you for joining. We're going to wait just another minute or two, and then we'll get started. If you know how this works. If you have any questions or whatever, either use the Zoom chat or speak up, and we'll start in a little bit. All right. Hi, everybody. Again, thank you for joining. We'll go ahead and get started in a minute. By way of just some announcements that I think we'll make at the end as well. As you know, we're going to transition to once per month meetings. So this will be after this. So this is the first one of July, and so following this one, the next one is going to be the first Tuesday of August, and we'll continue on with monthly, uh, roughly 2-hour meetings from now on. We want to welcome all the newly incoming fellows. Last week we dedicated a session to the graduating ones this year. Today we're going to do a welcome thing. So with that in mind, we've chosen a topic for a short case-based presentation on MMA anatomy and MMA embolization, a topic that's of interest to a lot of people, and especially the incoming people, as this is one of the more, I think, emerging and more quote unquote basic embolization procedures that we do. Uh, Nevertheless, it's everything is full of surprises, especially if you look. There's a lot of interesting things that we can learn from this. So Eitan has prepared. He was going to review a really really a very interesting case. There's a lot of learning points, and we'll use that as a way to discuss the technique of the MMA Embo in general. Let me stop the share. All right, on. Thank you so much. You're on.
You want me to start?
Yeah, let's go ahead.
Oh, I see. Okay, hold on. I have to connect the packs.
All right. Thanks. So if anybody, as people join, if you have questions or comments or whatever, feel free to use the Zoom chat, or you could just speak up. Otherwise, you know, we keep ourselves on mute so that the background sounds are less. And we'll, you know, if you have, again, like it's a topic that's of good interest to a lot of people. And the anatomy is, I think, well worked out, so it's well worth presenting at this point.
Can you start with the other case? I need 2 or 3 minutes here.
All right. Okay. We can. Okay. Let me do something. 1 second. Let's see what we got. All right. So why don't we then go ahead? What we'll do is let me go into some very brief review of the underlying MMA anatomy. Maybe we'll do that off the neuroangio page, and then we'll go ahead into this case. Let's see. All right. So this is just by way of very quick review, and this is off of the neuroangio page and the middle meningeal artery. It's you know, obviously feel free to look at the whole page for all the information, but essentially what in terms of middle meningeal embryology, I think we're going to skip over that, but we have some interesting there are some interesting points there. But if we go over to the quote unquote adult phase of middle meningeal artery anatomy, the schematic kind of shows like what a lot of you know, I'm sure, that middle meningeal usually is a branch that of external carotid arises from the proximal imax, and is responsible for a lot of supply of the dural convexity in connection with the anterior and posterior meningeal artery. So there's a lot of anastomoses there. There's a lot of interplay and balance. You know, you see a lot of reconstitution of MMA territory from other territories, like especially after, say, craniotomy, where the MMA might be sacrificed or otherwise out of commission. There'll be other arteries resupplying the area. In terms of connections, the important points, if you want to just be like keep it very basic, essentially at the proximal, when the MMA goes through the spinosum, as soon as it enters the cranial cavity, it usually gives off a branch that participates in the supply, called the petrosal branch, that participates in the supply to Peter's bone, and particularly the facial nerve and the petrosal nerve are the ones that would be at risk over there. So one of the kind of points, like if you want to say position one of concern, is a proximal MMA position. So any embolization that's carried out proximally, very proximally from the MMA, from say a foramen spinosum location, would potentially risk the facial nerve. The next position is a little bit more distal, and that's the connection with that the MMA not infrequently makes with the ophthalmic system, and that's the one that people kind of like always think about is, or should be thinking about, is the connection to the ophthalmic system and the potential for blindness that arises from there, and that's located kind of just a little bit more distally. Maybe we should go over that a little bit later. I don't know if Ethan, if you're ready, we can jump to your presentation. But essentially, there is a connection. There's an embryonic connection that exists between the ophthalmic and the MMA. That connection is a continuum. So we think of it as like, say, there's a PCOM P1 continuum. You can have a fetal PCOM. You can have almost no PCOM at all, and then a balanced thing between posterior communicating and P1 segments. There are many other examples of similar dispositions, and so the MMA ophthalmic connection is on that spectrum. You could have the more classical situation of the ophthalmic system being supplied from the classical ophthalmic artery. There is the meningeal ophthalmic variant, which is the extreme of essentially the entire ophthalmic system being supplied through the meningeal artery. And then there is there's a spectrum in between when there is codominance. So the meningeal lacrimal variant, for example, which is where the MMA supply is quote unquote limited to the lacrimal gland, would be on the spectrum of that. But the connections are, the connections always exist. It just depends on the size of them and the hemodynamics of them, and it's important to be aware of that. So if we go down here, we'll skip the hierostepedial thing because I think that's not germane to what we're talking about. Let's skip over that. So we can skip over that as well. A lot of very interesting rare variants here. Aberrant carotid, that's another interesting thing that we can get into a little bit later. Here's the meningeal ophthalmic variant. So that's the schematic of the middle meningeal supplying the ophthalmic system like that. And that's the corresponding image. You see a left ICA injection. You don't see an ophthalmic artery from here. It's one of the things that we teach our fellows is whenever you do an injection of the carotid system, always one of the things you should look for is the ophthalmic artery. If it's not there, chances are it's coming from the MMA, from the external carotid. And so here's the injection of the external system. There's a little bit of reflux into the ICA. And here you see the meningeal ophthalmic artery and you see the blush of the globe. That can be recognized on MRA as well. Even this like older sort of like, this is not what a modern good MRA should look like, but you can see here the more classical ophthalmic on the left, and the, there's this kind of a suggestion of a different origin of the ophthalmic artery here. And that you can see that much better in modern MRs. So some other examples. One of the things that we will keep coming back to, and that I think is, so here's an example of a meningeal lacrimal variant. So here's an injection of the internal carotid artery. You do see an ophthalmic artery. You see the blush of the globe over here, but it kind of like looks like the artery is a little bit small, maybe a little bit less in caliber than you might anticipate. And here's the ECA injection of the same patient. And you see here in the frontal views, here's a little bit of motion, so that outlines the orbit. And so you see how there's a middle meningeal artery. There's a branch that projects over the lateral aspect of the orbit. And then in a later phase, you see a blush here, which is the blush of the lacrimal gland. One of the things that we always come back to is this notion that if you see anything that's if in a frontal view, any branch that's overlying the orbit, when you do an external injection, any branch that overlies the orbit is likely to be in the orbit or related to the orbit. That's one of these kind of like maxims, so to speak, that you should be aware of. Why is that? Because usually the occipital artery, which is the other thing that could be maybe extending like posteriorly and be projecting over the orbit in a frontal view, typically doesn't extend that far medial. And so or at least it doesn't extend that far medial in the standard sort of like projection that we use for the frontal views. So if you see anything overlying the orbit on an external injection, that's one of the things we look for. Again, like just like on an internal injection, look for the ophthalmic, and the external injection, look for something like that. If you see that, just, you know, keep that in mind, work it out if that's relevant to your procedure. Work out what exactly is projecting over the orbit, and chances are it's going to be some kind of MMA contribution to the ophthalmic system. The recurrent meningeal is the other. Is again on the spectrum of meningeal origin from the ophthalmic system. There are variants of that and whatever, so that can impact the MMA embolization, of course, if the MMA doesn't come from its usual position. If it's like that, then you have to really weigh very carefully whether or not you want to catheterize this artery via the ophthalmic. I don't think there's a lot of appetite for that lately that I've heard. And certainly that would put vision at risk. So we have some other examples, but whatever. This is actually much more common. This is much more common than the meningo-ophthalmic variant. So the recurrent meningeal variant is way more common than the meningo-ophthalmic, and there's a lot of examples of that. So here's an example of an injection. Usually you see that best in sort of late arterial parenchymal phase, because typically the transit time through the middle meningeal system is a little bit slower than through the brain. And so if you do like a nice short injection, the arterial phase of the brain has washed out, given way to the parenchymal phase, and then you see still the artery of the MMA overlying the parenchymal blush here. There's actually early venous phase here. There's another example of the same late arterial phase. You see this branch here, just the frontal division, and here the parietal division is coming from the external system. Anyway, so this is just like a brief introduction. Any questions? Let's see what else is going on. There's some questions here. Are most people using GAO conscious sedation for MMA Embo? What are people doing? We use, either one or the other. Anyone does them totally awake? I'm not sure. All right, Eitan.
Yeah.
Go ahead.
Okay.
Let me stop this screen share. Okay, you're on.
It's disabled, the screen sharing.
What? Oh, sorry. Hold on one second. Okay. Sorry. Should be good now.
Okay. So, okay. So this is the case of oh, this is not the right screen. Okay, I'll leave it like this. It's okay. The story of a gentleman who like this is from the admission 1 month before the current admission. He came to the hospital. Actually, he had a full workup. He had some strokes like symptoms, and the MRI showed that he had like an ischemic infarct of the pons, midbrain actually, and we see this like a classical shape of a medial basilar perforator. But this having this MRI, this baseline MRI, is going to be important for the follow-up to better understand what's going on. At that time, also CTA is done, showing like diffuse intracranial atro. Approximately 1 month later, the patient has a little trauma, but it's a trauma in which he hits his face, and he arrives in the hospital confused. And at that point, they do a CT. and the CT shows the following. So there is a subdural hematoma involving the tentorium, the falx, the convexity, and the subdural hematoma extends also like along the clivus down, and we see here like on the sagittal view very well how it extends up to the craniocervical junction.
Eitan,
Yeah.
some comments on the Zoom chat. Is there any way to make the images bigger? I know that you have a vertical screen, so I don't know.
Yes, there is. So I will have to do this. This, and then I have to change the monitor. I have to change the monitor that I use. And I'll do this. Share. Okay. Is this okay?
Yes, great.
Okay. So again, this was the initial CT. This is the MRI showing the infarct, but yeah, you know, like a lot of chronic lacunar infarct, sort of like an état lacunaire, maybe enlarged vessels, like due to intracranial atrophy as confirmed by this CTA, but certainly no subdural. Also, there is on the subdural involving the tentorium, the falx, the convexity, also maybe a little on the other side here, and extending along the clivus. This was managed in the traditional way by neurosurgery. They first observed a couple of days because the patient was not doing too badly, and these are sequential CT. And this is the day, a few days after, like I believe 3 days after. This is like 4 days after, and then they decide to put this device, which is a subdural evacuation port system, and this is the control after that. And like 2 days later, and at that point we were asked to do an angiogram with MMA embolization. So. So this is the angiogram. You see the screen? No. Okay. Okay. Now I go back to screen 1. Okay. And this is the angiogram, and so we decided to start from the right side, since we knew that most of the work we would have done on the left side. So we started on the right side. We do just check the internal, and indeed it shows like intracranial atherosclerosis here with sort of like a fusiform dilation here, also with it's hard really to call this. It is an aneurysm dilation, but really like based on atherosclerosis. Here you see a very nice pituitary branch from the MHT. And then this was a radial approach initially, and then we concentrate on the external carotid artery. And so here, this is a run of the external carotid artery, because the decision was to start like embolizing the medial part of the falx, in order to overcome like to close off the potential collaterals to the falx and to the left side, once the left side would have been embolized. Essentially, the rationale is that if you just embolize from the left side, then these collaterals from the right side would just like immediately like take over and fill again the meninges. So by closing off this side too, like we would limit that to happen. So we do this run of the right external carotid artery, and what you see here, you can recognize immediately that there are some variants. External carotid artery, superficial temporal artery, internal maxillary artery, and here we have the middle meningeal artery coming up, and then this is the foramen spinosum region, and then here becomes intracranial, and gives off this picture squamosal branch, pretty large, and then it continues here to give off this like posterior sort of frontoparietal dominant branch, but it also gives this branch that goes anterior and toward the orbit. You see it projects on the orbit on your bone view. On the AP view, same thing. You have the middle meningeal artery, petrous, the foramen spinosum. It turns, okay, and then it gives the petrosquamosal branch and this frontoparietal branch, and gives this branch which goes medial, goes toward your orbit, and this is the same branch that we were seeing on the lateral view. And in order to better understand, we did or better visualize, we did a 3D, and here you see like the same thing. Middle meningeal artery coming here, okay, and then giving this branch goes medial toward the orbit. And the same thing can be seen also on the cross-sectional images from the 3D. And so we can understand very well where does this vessel goes through, okay? And so we can follow this vessel. So middle meningeal artery, here goes up. This is the point. This is the point where it gives the branches to the seventh nerve, and then turns up. And then here it divides into the petrosquamosal branch toward the back, the frontoparietal branch here, and then this frontoparietal branch, this gives one, which is the meningolacrimal, the lacrimal branch. And we see that the lacrimal branch gets into the orbit through its own foramen. Doesn't go to the orbital fissure. Superior orbital fissure here is far away, it's like around here. And this goes through the orbit through its own fissure, through his own foramen, and then gets into the orbit. And in this case, it stays lateral, and it supplies certainly the lacrimal branch, but potential connections are there. Even if you don't see a direct connection between the lacrimal portion and the ophthalmic, the potential connection is there. So, so at this point, we decide to try to catheterize this and go very distal, and in order to occlude this area of the right meninges. And we managed. So here we use this is just the Simmons catheter that we were using for the radial embolization. So it's a 5 French catheter, and this is a headway duo, and we managed to in this side was an easy catheterization, and we could go very, very distal. And this is like the angiogram from that distal position, and we see filling of these branches, and with retrograde filling of other branches that are connected. And this is the same view from the AP that shows indeed that we have filling also on the other side. By doing a hand injection here, we feel like the meningeal connection with the other side, that we know they're there. And at this point, given the position, very distal, like we felt appropriate to start injection of Onyx. So, this is the start of the Onyx injection. This is what you see here is Onyx, which comes out of the Onyx of the headway duo catheter. And initially it fills obviously branches, but then after a little it starts filling some spaces that are really like not arterial spaces. Here is the same thing from the lateral view. Again, filling of some branches, and then starts filling some other spaces. We keep going, and this is just another view of the same thing. It keeps filling like sort of like little, I would call them like lacunar spaces that are certainly not extravasation per se, okay? They are contained, but they don't seem to have the shape of the arteries that we were visualizing before. Pull back a little on the catheter to feel more like these branches, and now again it finds some branches, but it also like then opens up in in some of these sort of lacunar space. Same thing, like keep going again, like it feels some arterial branches, like here, these are obviously arterial branches, but also like it opens up in some other spaces. So, so come back, and without doing too much here, no reason to do too much, come back up to this bifurcation. And then when you inject, we feel this, but also like, look at this. This is like a classical tram track appearance of the meningeal vein that runs by the artery. Just by injecting onyx, nothing was done. And again, like the catheterization was very, very smooth. And again, so this is onyx that is feeling like the meningeal vein. So come back at this point, just feel again like this, just a little in this bifurcation, and then we decide for this to be the end of this side, which was again the right side. We remember that most of the hematoma was on the left side, and this is a control angio that shows persistence of more like the frontal region of this in this hemisphere, but like embolization, like no visualization of these other ones here that were embolized, and certainly like persistence of the lacrimal branch that in this case was certainly not put in danger at all by the embolization that we perform. And this is the final right side view that shows where the onyx went. So one of the comments and questions here is, what happened here? Like, where did this onyx go? Is this this look to us this sort of little venous connection, and this is a typical, very, 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 very almost like the rule when the onyx is injected distally like that. What's the significance? It certainly doesn't have any, like, we never associate these with like a hematoma or a venous thrombosis, but it's something that would be good to better understand. So at this point, we move to the left side, and this is it was a hard catheterization from the radial to get very high in the left common carotid artery. So we switched to femoral for that. Once we inject the left common carotid artery from below, like, we realized that there was something else too. And this is where, like, this case becomes super interesting, because here you certainly see like a little mass effect. You see like the brain is pushed a little to the left. There's the image of like a subdural hematoma here on the falx that we know is there. But here you see also an extra finding that was unexpected. Here you see like there is an aneurysm. And here we see that better from the lateral view. So there is an aneurysm here that certainly we know for sure was not there on the MRI a month before, and on the CTA a month before. This, like, we really felt this was like a traumatic pseudoaneurysm and likely the cause of the problem. But before concentrating on it, we decided to finish the subdural MMA embolization. So this is like the external carotid injection on the left, and here you see again like middle meningeal artery, foramen spinosum, petrosquamosal branch, a very, very almost mirror appearance. And here you have this branch that goes toward the orbit, okay? And when you see this branch, it goes toward the orbit, like, look, we try to correlate on the AP view, and it's this branch here, okay? And we see here it's a little more dominant than on the left side, and you see how it goes also much more medial. So here probably this is even more dangerous than the right side. And then we again connected our catheter with a flush and go with our micro catheter in order to try to embolize this MMA. So what happened here is that during the navigation we could get the wire. We could not pass essentially this point easily. We didn't we didn't try to change too many catheter, too many wires. It was stuck here, as often happens when this is tortuous. But again, we didn't try too hard, but it tend to stop here, and we could have been more aggressive, certainly like try the catheterization, but it stopped here, and that's okay. It's not a big deal, because if you have a more proximal position from here, knowing that there is a meningolacrimal branch, certainly you don't want to inject onyx, but you can go with particles, and particles is a great solution for this. It's actually, it seems to me even to be more popular among neurointerventionalists as a solution to treat MMA Embo. And this is a perfect position for particles. And particles, when you inject particles, you can be careful enough not to have reflux and go to the meningolacrimal. And so that's what we did. And this is the position, and this is the initial injection of particles. And we see that particles fits very well all the territory, and then it starts to involve other the adjacent branches too. And this is like an image of particles going to the vein. So that's why it becomes like a negative image on the roadmap. And we had a very good permeation of the meninges. All that you see here on this negative on this roadmap is essentially like the filling of the meninges. And this is the final.
So Ethan, just to clarify,
yeah,
the image was the negative roadmap. I think what happens here is, I'm not sure if the particles penetrate into the veins. They may, and that's one of the criticism of the particles, is you don't see them. I think what happens here is that as we fill the territory with particles and contrast, the particles lodge in the arterial system. And so that diminishes the outflow of contrast. So the contrast saturates the meninges. And then as you change the syringe and you start injecting the artery again, in delayed fashion, you then see the previously injected contrast then starts as it exits the meninges, and you acquire a new roadmap. It is seen as a negative image because of the continued sort of aggressive contrast that was previously injected. Kind of like if you do like a test injection and you get a roadmap too soon in the arterial phase, you still see the contrast in the venous phase. So I'm not sure if the particles penetrate into the venous spaces here. That's one of the questions that I think is asked about particles. And we'll probably come back to that because we want to discuss what happened on the other side with the onyx.
Yeah.
Minor point, but everybody can see how you can achieve a very distal penetration with small particles. We use 45 to 150 particles here. We typically do for MMA Embo, and you see here the territory that was injected. Anyway, yeah.
At the end, from this position, we had a little onyx left from the other side, so we injected just, instead of a coil, we injected just a little onyx, just a little drop that was left in order to close the vessel. You can use a coil. You can that doesn't matter. But here you see this little onyx that was placed there, and now this is the final view, showing again your meningolacrimal branch pretty open, and the convexity meningeal branches not filling. So this is it for the meningeal embolization and of this side, and then we had to concentrate on the probably the most important, certainly the most important problem in this gentleman, which is this aneurysm, which obviously being not there 1 month ago and there now also with this appearance, this was a traumatic pseudoaneurysm, very interesting appearance. As you see here, you have this pericallosal going here, bifurcating in two, and then from this vessel, it seems like this really like this aneurysm develops from this vessel and extends like that. We'll show you better selective images. Yes, so these are, so we went, again, we use actually the vertebral catheter as our guide. We went with a headway duocatheter, microcatheter, and this is like an angiogram from the pericallosal, that shows, on this lateral view, again showing this pericallosal giving this branch, and that then divides into two, and this is the branch that gives off the aneurysm, and you see that this branch continues here to supply the mesial inferior parietal lobe. Now, what's interesting here on the AP sort of like oblique view, you see that the aneurysm like extends medially, and it extends medially in an interesting way that I'll show you briefly. Catheterization was relatively straightforward again, and this is the aneurysm. And what is interesting when injecting from the this actually, like after the aneurysmogram, we injected just a little contrast just to see like exactly where the outflow from that vessel would have gone, which territory. And once we started to coil, we decided to coil these in order to, instead of glue, because we wanted to limit the amount of embolic material to go distal and fill this territory. While if you just coil these, like then you can hope that this territory can get retrogradely filled a little more from collaterals. But here in this very, very interesting image, this is an AP view, which shows that when we were starting coiling, this is the coil pushed, we observed like in delayed fashion what happened to the contrast that was in the aneurysm, which is leaking. It's leaking medially. It's leaking medially through a hole, and it extends to the subdural space. Like really like confirming really like that the whole issue in this person, like certainly he had a trauma, and he had a traumatic pseudoaneurysm that developed, opened up in the subdural space, and then from here, like the subdural like extend all the way. And we know that subdural hematoma can really like connect to each other, like supra infratentorial right to left side. But really like this image like confirmed that this is really like the culprit of this subdural hematoma. So so we coil these and show you this. So this is the final. We decide to come back and put really like just the proximal part of the vessel, and this is like post-coiling. Again, you see like this all the contrast that leaked from the aneurysm to the subdural hematoma, and this is the final showing occlusion of obviously that branch, but preserval of the other branches, and this is the subdural hematoma. We see better with the mass effect on the brain, and this is the final angiographic view showing again the coiled aneurysm, a little subdural hematoma, stable, and no with no other issues here. Like this is the final, this is like the CT post treatment that which with the coil. If anything, this is the contrast in the subdural, and on the falcine subdural that came from the aneurysm. This is instead the contrast with particles that was injected on the left middle meningeal, and here you see the onyx in the right middle meningeal extending all the way to the superior sagittal sinus. The patient woke up fine. He's doing very well actually. He didn't certainly didn't have a clinically symptomatic inferred from this sacrifice. So I think the interesting points from this case, certainly like one thing, subdural hematomas sometimes can have other causes. We showed in the past subdural hematomas caused by a dural fistula. This is an example of a subdural hematoma caused by an aneurysm, traumatic aneurysm. That's certainly an interesting topic. The other interesting topic regarding more like MMA Embo technique. First of all, look at your anatomy. Like, okay, meningoacanal branch. What is, where is it, how to recognize it, what to do when there is a meningoacanal branch. Doesn't mean that you have to cancel your MMA Embo. It just means that you have to adjust for that. Being distal, and if you're very distal, you can Onyx, liquid embolic agent is reasonable. If you're distal but not too distal, you have to think of using particles, which you can control the reflux. Even if you see the meningoacanal branch not really connected to the ophthalmic per se, but like we have to assume that that connection is there. This is a procedure in which you really want to be safe, and it's not reasonable to risk a vision loss with such a procedure. What happens with the Onyx when it's distal and you inject and you see this filling of these lacunes? This is, I'm happy to hear opinions of anybody. To me, like, these are little veins, little lacunar veins, sort of spaces that we know exist in the meninges, and probably the Onyx goes from the artery to these veins. Why that happens, even if the Onyx is injected very slightly and without much pressure, I don't know. But we see that pretty often. And use of particles, again, like when you have a position, like particles is a perfect, great way to treat this. And there are situations in which that's your only option.
Okay, there's some comments. Ethan, thanks so much. Thank you. It's a really great presentation of an awesome case. Of course, it's unusual, but in discussing this case and showing the case, as you mentioned, there's a lot of learning points about the technique of MMA Embo and different agents and all of this stuff. So there's some questions. Vikas is asking liquid embolic versus use of coils in the pseudoaneurysm. I think Eitan addressed that. Eitan, if you want to mention again why we chose not to use like glue, which
I don't see the question, but yeah. So you can use a liquid embolic agent there, but it's possible that the liquid embolic agent, other than filling the aneurysm, would go also distal in that branch, and then you would close that vessel distally, while so preventing a possible retrograde filling from the adjacent leptomeningeal collaterals, like helping and filling that. So keeping it alive. If you just coil, then you let that possibility to happen. So this is like a relatively silent territory. That's why I don't think it was paramount, but if you can choose between the two, like here, there is a reason to choose coils.
Yeah, and I would also add that, like, when you saw the runs, the microcatheter runs that we had inside the aneurysm, there was a runoff, obviously, like the contrast was running off into that distal branch, which means that we don't have what's called a wedge position, an occlusion position. So we're not really controlling outflow. If we had a wedge position, I think we'd probably use glue, which is we favor glue for these things normally, but you see how there's outflow into this branch. So that means that it is possible that pieces of glue or onyx or whatever are gonna fly off distally into that branch. And I don't think there's enough collateral to retrogradely fill the whole thing, but if there is enough leptomeningeal collateral that would fill the cortical, the gray matter sort of territory of this, I think that might be somewhat helpful. So that's why we chose to use the coils in this case.
Sappi says the medial subdural hematoma should raise suspicion. Yes, retrospectively, yes, you're right. I mean, it was a suspicious image, and especially this image here. Where is that? This image here. That shows really like there's a part of this hematoma seems different. Now everything makes sense now, right? But certainly like it was suspicious, and so probably like a CTA or an MRI should have been done. I mean, at the end, like it would have been better to know before, but at the end, in terms of outcome, it turned out well. The pseudoaneurysm could be treated with coil basket and small amount of glue proximally, minimize risk of re-rupture and preserve distal retrocollaterals. Yes, that's a good idea. I mean, there's really like no feeling of the aneurysm, so in this case, I'm not concerned of a refilling and re-rupture. You know, this is another technique that certainly can be used, just like a drop of glue proximal instead of coming back with a coil. It's an option. Size particles, small particles, 45 to 150 contour PVA particles. I don't know if Dorothea or somebody else have a different idea on which particles to use.
Yeah, I think people, I mean, generally, probably we would say smaller is better. So we usually go with 45 to 150 contours. We had that talk on one of the previous BANANAZ. We spoke about the different types of particles. So in a skull base meningioma embo, I think that's the kind of particle makes a big difference. In that the contours are they're relatively spherical and they're more effective at embolization. So there's as you probably know, there's data in fibroids that they work better than non-spherical ones, but they're also better at taking down nerves. And like Orset said, like nasal septal necrosis, if you're doing an epistaxis embo with embospheres or something like that. So I mean, certainly you're comfortable with what you have experience with, but we prefer the contours because they're not exactly spherical. They're randomly shaped things. And they also come in 45 to 150 range. So 45 is rather small, but you have to be more careful about the collaterals. And that's Yafel is asking, assuming no meningeal lacrimal branch, typically use onyx or particles. So yeah, I think we typically use particles. Like Eitan would just say, more often than not, we would use particles for MMA. But the thing with onyx distally and those spaces, it's not, I mean, I'm sure, I don't know if anybody can say.
John Scott is saying that it's common to see AV shunt opacification with catheter wedged. Normal, he said there are normal precapillary AV shunts.
Let me go back. Precapillary AV shunts related to what? To the, what you said, onyx?
No, I guess he means just normal anatomy, like that. There are in the. I think he means this is normal situation in the medial meningeal artery. There are precapillary AV shunts that when the catheter is wedged, you open it up with onyx. I believe that's what he means.
John, you wanna? I don't know if you wanna speak up. If you have mic access to comment.
Yeah, it's my understanding that there are normal precapillary shunts in all systemic tissues. You know, I haven't read much about it in recent years, but it's pretty, you know, you see it pretty commonly if you have a catheter in a wedge position, say in the face somewhere, and inject contrast, you can normally see AV shunting. And it's my understanding that the shunts are there and thought to be used for temperature regulation. But I think probably I think the onyx is probably in small venules pushed through these shunts.
Thank you. I mean, I think it's like a lot of this, we probably need to understand more. Because when we go into the whole idea of fistulas, right? How does that relate to dural fistulas or other fistulas? It raises that question immediately, right? What are these, if these shunts exist, is that related in some way? I think that like, so one of the reasons people suggest using Onyx in MMA embos, I mean, it's like all kinds of different ways to skin this cat, looks like, and a lot of them seem to work, thankfully. But one of the ideas behind using Onyx is that you get, like, quote unquote deeper penetration than you do with the particles, right? If you use a liquid embolic like Onyx or dilute glue. So last time we had a presentation on using like really dilute glue, meaning mostly oil and not so much glue, to go like deeper. But I think when you go further, there's a possibility that you could go so much further that you're not in the artery anymore. Whatever these spaces are, they're not like, they don't seem to be like what we would think are arterial spaces. So you're arteriolar, capillary. My personal belief is that we actually rupture the arteries. I think we rupture them. Like the Onyx, it doesn't take a lot of pressure, especially if you have a little bit of reflex, to rupture these little arteries. And then the Onyx either ends up in some parenchymal space, like just like.
But if
or in a vein, like so that
if it ruptures, if you rupture the artery, then you would expect, you know, at least sometimes to see like a subdural hematoma, a subdural like sort of like collection of Onyx, like would be like a smooth, like more like focal like collection, and that we never saw that. I've never seen like an epidural like collection after these.
I think it depends how much Onyx we allow to escape. Like here, there wasn't that much. And if you look at the CT post, like there's a little glob on that CT. It's just not very big. I mean, some of it I think finds a way into the veins, whether like John has said, like via these connections, like that last image you showed is a middle meningeal vein, right? That's like the tram tracking appearance of that. And anyway, I don't know if it's how important this is, but it's a self-sealing phenomenon, so I don't think we see bleeding from that. By definition, by the time that happens, the artery is like plugged up with Onyx proximally. So Sadi is saying using 4-to-1 glue and particles. Yeah, I think that's people's like sort of, you have to be able to use like this or the other depending on where you're in, right? If you're in a very distal position, like you were on the right, there's not a lot of forward flow, so you're more wedged. So right, so the particles are not very effective when you're in that position because there's no runoff to carry them distally. And so in that case, like a liquid embolic is going to work better, probably. That's at least the rationale. Anything else? Any other comments, questions?
Maxim, can I share my screen? Can you hear me?
Yep.
Kitty Pong here.
Yeah.
Can you hear me, Max?
Yes.
Okay. Can I show my screen for a little bit? Because I was looking for a file trying to concerning the how you entered the venous site by injection of the Onyx. There's a literature. I think it's quite a famous one.
Eitan, can you stop sharing your? I think
I can override him. Okay. Can you see my screen now?
Yeah.
Okay. Maybe you have seen this article before. It's written in 1970s, describing the macro and microvasculature of the dura mater here. And in this article, it says here, arteriovenous shunts are present in the mid portion of the dura, which may function to bypass capillary network or something. So what we are seeing might be part of this. There's an illustration here. Maybe this is the, well, he's saying that this is like you know, the primary anastomotic artery with its accompanying veins. So there's some, you know, connections between the arteries and the veins. And we also see, yes, I agree with other people comments too, because yeah, we do sometimes see when we have the microcatheter in the wedge position, the contrast enters the vein somehow. Sometimes we think we ruptured the vein, the artery or the junction, but it doesn't seem like that. It goes away. So it's not. It's we're just opening. We just open the connection between these arterioles and the veins by the pressure injection. So this might be one of the explanation. Just to add a comment.
Thank you, John. Are you seeing this?
That's what John said.
Yeah, probably this is the one he was talking about. I was trying to find it on the
Yeah, that's exactly what I was trying to describe.
Awesome.
Yeah,
that's awesome. Now, why when we inject the dye we don't see that? Like when, like, you know, like.
Well, you can if you inject hard enough.
Yeah,
I injected very hard and.
Try harder.
Okay, I'll try harder. But maybe, like, you know, it's like, you know, when Onyx goes, like, maybe it closes distally, so and then the pressure of the Onyx, it goes into different directions than the pressure of your contrast.
I mean, once there's a proximal plug, that's a very hard, high pressure, becomes a very high pressure injection, effectively, right? So that would go along with what's emerging here. Cool. Okay. Amit is asking what's the best time to do this, meaning like the MMA Embo. When to do it, pre-op, post-op, like wait a few days. I don't know. Seems like most people wait a few days after doing a seps or whatever. Right? Like, what do people do? Is there do we know when we should embolize? What's the timing? I don't know if there's any like great guide on that. Let's see. So I want to
theoretically, the earlier the better, right? The earlier you embolize, the better, because you're trying to prevent progression of the subdural, and also you're trying to prevent recurrence. And in the recent emboli study, which is the Medtronic study using Onyx for subdurals, you actually, even before you operate on the patient, you have to do the embolization before the actual surgical procedure.
So I guess one rationale for that, Henry, would be that if the surgery like somehow ends up transecting one of the branches, you would not be able to embolize effectively into that territory, or is there?
Well, that's true too. That's absolutely true. But I mean, typically for subdurals, they are, you know, either burr holes or very small craniotomies. So typically you're away from the major branches of the middle meningeal artery. So you should still be able to potentially embolize afterwards. But for some reason in the protocol, I mean, and I don't think I'm not saying that I know the answer as to, you know, when is the optimal time to do the procedures. I will say this, I missed the beginning of this, but I assume this was like an extravasation of Onyx during injection of a middle meningeal artery. Yes.
Part of the case is that, like, a part of showing how Onyx, I mean, distally. That's
I have ruptured many vessels with Onyx after you achieve flow arrest, after you achieve a flow arrest position, even intracranially. But because you're embolizing with Onyx, the vessel's already occluded anyway. You can rupture the vessel and it doesn't necessarily do anything.
Yeah.
But in terms of timing of embolization for subdurals, I don't think anybody knows the answer to that yet. You know, and the studies will eventually give us some guidance as to when, you know, whether liquids are better than particles, et cetera, et cetera, et cetera. Obviously, the industry-sponsored studies are all liquid embolics.
In the short term, from what we've seen now, right, Henry, it doesn't seem like there's a major difference between particles and liquids at this stage. So
I don't know, you know, to be honest with you, Max, I don't know that we actually are doing anything for you know, with the middle meningeal embos, but there is no difference clinically for sure between particles versus liquid embolics.
Yeah, either in safety or in efficacy.
In either safety or efficacy. The one thing that I am impressed with is the vascular blush. You know, you definitely get a much more vascular blush with the subdurals than I would have anticipated. That is for sure.
Yeah, and I think
I
that
mean,
we didn't really cover today because we wanted to like show something a little bit more unusual. But
yeah,
but yeah, that's I think that's well known, right? For like people that do this,
yeah.
they all know what these membranes and all this stuff looks like. And it's very impressive, right? Right. So I just wanted to, so let me very quickly just follow up on what Eitan showed. I wanted to, actually, Kitty, do you have, why don't you show yours first then?
Okay. Okay. I'm working on two computers. One doesn't work well, the other one I'm not used to, so it might be a little bit
okay, so let me show
clumsy. I can go. I can go if you want.
Okay, let me just share my screen for 1 second. So this is just what Henry was talking about. Whatever, I'm sure you guys all, you see, this is like a typical subdural embolization case, not with an unusual aneurysm. This is like an MMA injection of a person with a run-of-the-mill subdural, and you actually see these like areas like areas and whatever, all these vascularity related to the subdural. That's like anyway. Okay, thank you. All right.
Okay, maybe it's I don't know how this is going to work.
Yeah, that we can see the screen.
Yeah, I think you can see the screen now. So this is like a very strong injection of the MMA. Okay, I think you can see the whole system, the connections. Just repeating what Eitan has just shown you. We're at the level of the supporting spinosum with the catheter. It was probably wedged or something, and we did a very strong injection, and there's a meningioma over there. You can go through the branches. There's very small branches over here, which runs at the base of the skull. Small, but these are important. Like it can be. I think we need to mute some. I hear some music. Anyway, so we move on a little bit more distally. So this is the part that you have to be careful about, the branches that will go to the facial nerve. And we go up here and you see this one going to the orbit again. But we don't see the choroidal blush over here, because actually this is not feeding the whole system of the ophthalmic artery. Usually the branch that you see coming from here, it will mainly be related to the lacrimal artery. And you can see a very beautiful system of this, you know. There's like a paired artery on the left side and on the right side that runs along the superior sagittal sinus. You can go all the way back to the posterior fossa. Actually, I have another picture to show you. And interestingly, you see something over here. You only inject from the the middle meningeal artery, which is considered to be something that it feeds the supply the dura matter of the supratentorial or the cranium falls and also the skull base. But you can also see on the same injection that you can see something in the posterior fossa dura matter. So what are these? I think these are the channels that you see. Usually it connects the petrosquamosal branch of the middle meningeal artery. Usually it runs along with the path of the dural sinus, like the transverse sinus, the sigmoid sinus, and eventually, probably what we are seeing here is a branch that is connecting to the occipital artery. We don't see the end of it, but probably this is the mastoid branch of the occipital artery filling retrogradely because of the pressure injection in the system. There's another injection here, different patient. This patient had a shunt over here. We went in to treat him, but we saw the shunt just went away by itself. But instead, we see this again, an arterial network along the superior sagittal sinus running all the way here to join what we usually call the posterior meningeal artery. And again, this is probably a jugular branch or something of the either the occipital artery or the ascending pharyngeal artery. And again, you can see the branches that run along the path of the sigmoid sinus. So this is like an example of almost the whole system of what you can see in the system, the middle meningeal artery. There's some embryology, but I don't think we need to go through that. There's another set of slides. I just put some pictures for you to see again. So I was just put this in full screen. Again, we can just go one by one to name all the branches. But anyway, the other branch that I haven't mentioned, this is just another a connection probably of the lacrimal artery finally into the system of the superior superficial temporal artery. So it can reflux anyway. Okay.
I think there's only like a portion of the screen showing for some reason. There's a top portion that we.
Oh, okay.
Just now, like before this, it was great.
Uh-huh.
Some reason.
So we can. Okay, I will try again.
Maybe it's because like multiple screens is sharing. I don't know.
Yeah, I don't know. I try this one. Okay,
That works.
okay. Okay, this is from. I'll try again. See if it works. It's working now. Okay. Okay. Again, the same picture. I see the same things again. Just go. This is just to show something along the skull base. They won't go through that right now. We need more time for that. I just want you to show this one. So this is a run of a DSA injecting from the left external carotid artery, front of you. Okay. Again, a repetition of what Ethan has just shown us. So we don't see a lot. We don't see a lot of things actually. Nothing in particular, but anything. Anyway, you can see something over here, which is probably a little bit more easier to see on the lateral view. Just stop here. Okay, again. So this is not even a selective injection of the middle meningeal artery, but on the later phase, you can see now, different from the last case that I just shown you. You see the retinal blush here, which tells you that you have some connections between this external carotid artery system with somehow the artery that goes to the orbit. Okay, so there's some strange looking arteries over here. So every time you use a particle, onyx or anything, this is one of the important connection that you have to realize before you become too aggressive in your procedure. I've heard of stories like, we went to embolize a meningioma. We just particle. We thought we were safe, but we didn't push the catheter far enough. But we used larger particles. But the patient ended up being blind. And why is that? Because sometimes you have, you inject it softly, and you maybe you push your particles with a little bit back pressure to that, so it can enter all the connections that you don't really see before you make the embolization, or it can, yeah, can go through all this. So it depends on the quality of the pictures also. So the questions about, there was a question about whether you should do this under local or general anesthesia. We prefer to do anything at the skull base under general anesthesia. Anything over here, I think we're fine with local anesthesia, but it would depend on your preference. But we want to see a better picture. We try to make the patient still, and that's gonna be better under GA. Okay, so we run again. It would be very nice if you can pick up this kind of connections, looking at only one run of the DSA, not having to repeat it twice, 3 times. Anything you catch on the first run, you have more chance to pick it up during your procedure. Okay, so we go to the actual view of this thing. So what is the connection? Probably the same thing that Ethan's shown you. It's like this. I've added some pictures of bone also. You can see, so this is the superior orbital fissure. Most of the time, there's a connection at this outer edge of the outer, opening of the superior orbital fissure. But in this case, there's another foramen here. So this one is the meningeal lacrimal foramen, and I can show you the one with the vessel with this. So it runs through this very small hole made specifically for this vessel. So this is probably, it goes mainly to the lacrimal gland, but in this specific case, it also has a connection to the nerve that goes to the the retina, because we could see the choroidal blush. So this is something that you have to be very pay attention to when you do embolization in the MMA system. So this is the exact point that it comes. Usually it's at this level. So anything above that, you don't have this kind of connections. Anything below that, you have plenty of connections. Okay, I can just stop here. We can talk about the MMA for, I think, 3 hours, because it's a very important artery, and it has so many connections. This is something that I drew. You can go through this very slowly, branches that go into the orbit. You can have branches that goes up to the level of the superior sagittal sinus coming down here. So this is the Faucine artery coming all the way here to connect again to the anterior or posterior ethmoidal artery. And you can also have branches that extend all the way to the posterior fossa, the arteries that goes to the tentorium, and also the arteries that can connect to the internal carotid arteries through the MHT or through the ILT. So it's a very small vessel. It's not a large vessel, but still it has a very vast territory to supply. And when it goes somewhere, it has a connection to its neighbor in that territory. So it's something very important that you know all the connections before you try to do anything. Okay, that's it.
Cool. All right, any questions or comments? You go back maybe, can you show again that, wanted just to highlight a point on the video of the run that you had showed.
Lateral view?
Yeah, let's any view.
Okay.
So, and again,
let's go through this one. Okay.
Okay, perfect. So, you see how?
Sorry.
I'm sure most of you know this, but I just want to show, for anyone that's yeah, the basic points of like how in this very like selective injection, the force, like a lot of it depends on the force of the injection, right? As we inject in the arterial phase, we overcome the force of the pressure of the injection overcomes the pressure of the ophthalmic system. And so we transiently opacify this, the choroid, like those ciliary artery, the choroid blush that we see. Physiologically, most likely that's not the supply of this territory is not coming from the middle meningeal artery. In this particular individual, why? Because when the injection is like at the later phase of the injection, if you go through a little bit later, we don't see that anymore. And it might be, I don't know if the catheter is, it doesn't seem like the catheter might be wedged. It's a little bit hard to know. But you see how here in the later phase, we don't see it, but we still see the STA. So it might be a wedge, partial wedge position. But basically, it's just important to understand the hemodynamics of this. And that's what's at play, right? Like when we, sometimes if you do if the patient is not adequately anesthetized or if there's other technical concerns, you might do an external injection and feel that you've cleared the system. And there's no connection to the ophthalmic, but it just depends on the position of the catheter, the strength of the injection, all these parameters and factors. And then as the embolization commences, those factors change because we occlude the distal territory, so the pressures become different, so now there's more propensity for reflux somewhere else. A lot of it is just like details and experience, but I think one of the things that we could say, if you just want to say, okay, so like what's a simple recommendation? If we're doing an MMA Embo, like what's a simple recommendation to stay out of trouble? And a simple recommendation is to go distal. I think that's one thing that we could say, like where the connections to the ophthalmic system are going to be more proximal. Most of them are going to be along the sphenoid ridge, someplace area there. Beyond the sphenoid ridge, you're very unlikely to encounter anything that connects to the ophthalmic system. And so if you're not sure, you have to go distally. Now, when you go distally, the vessels get smaller. And so, maybe like there's less of a the particles might become less effective if there's no forward flow. And so then you have to like maybe decide what kind of embolic material you're going to use. But distal, like if there's a simple recommendation is that distal is safer. Okay, so a couple of, so Gilberto, if you decide for particles in this case, what are the size of the particles? We spoke about a little bit. We use small particles because they penetrate more. We use 45 to 150 contours. And I think those that use embospheres, like I think the smallest embosphere is a little bit bigger than the 45, but typically like people use smaller sizes. Do we mix the sizes sometimes? Sometimes what we do for tumor embolizations is we start with the small ones, and as the small ones fill up the distal territory, you see kind of like a tree. You see like initially you see this injection, there's a lot of blush, and as you continue the injection, you basically like lose the leaves of the tree. You think of it as a tree, so like then the blush disappears and you just have the branches are left and the leaves are gone. So the leaves are your distal territory filled up with particles. Then you just see the stumps. And then so then we switch to bigger particles and like chase that up with a little bigger particles. But I think the most effective particle embos are done with small particles. And of course, the trade-off of that is you have to watch your connections. The central retinal artery, I think if I remember, is like, it's something like 200 or so nanometers in diameter. So it's not a very big diameter artery, and it only takes a few particles to do the job. And so you have to be very careful. And the idea of I think we touched on that, the idea of reliance on bigger particles to in hope that they will not enter these little arteries, I think is sound in some territories. I probably wouldn't hang my head on the ophthalmic system with that idea, because I think it only takes a few particles to really cause a lot of trouble in that territory. But in other territories, we've done that in say we're embolizing a spinal tumor and we see a posterior spinal artery. We've chosen bigger particles because we think that, like, a lot of times embolizing like not a very big posterior spinal is fine, especially if you use bigger particles, but that's like a little bit more, you know, the gestalt of it. Anyway, any issues with billing and insurance? Billing for extra versus extracranial. Okay, billing. Well, we're gonna put Henry on the spot here if he's still around. Henry, do you see this billing section? Henry, if you're around, do you want to say something about that? About coding, billing, or no?
Sorry, guys. I'm actually in the middle of a spinal angio right now. What was the question?
Henry, thank you. There was a question from Sadi about billing and insurance for MMA embos, basically like anything about billing. John Scott says 61624.
Yeah, there's no, there's no. It's such a new procedure. There's certainly no CPT code for it, but yeah, it would be 61624, and it would be all of the angiography, internal and external angiography codes, et cetera, et cetera. It would be also the 36218, the add-on code for additional third vessel angiography, but it's, that would be the convention that would be, certainly as of now, utilized for billing of these procedures. So it's as much as an aneurysm coiling or a meningeal manifestation.
Henry, thank you. Sorry to, yeah, thanks.
Yeah, I'm gonna go back to my procedure for a little bit.
Amen. Thanks so much. I didn't see an inpatient, but I've been able to roll for outpatient from Peter. Yeah, I mean, there's a lot of, as you can imagine, with a procedure like MMA Embo, and again, this is like a little off topic because this is not like strictly vascular educational, but obviously there's a lot of appetite for potentially moving this into the outpatient realm with all the implications thereof, and I don't know like how exactly that's going to evolve, but I think I would just say, there's a whole other universe of considerations that goes into that, depending on your setup. But I would say that from the anatomical standpoint, depends, like a lot of outpatient sites are not like, it depends on how much anesthesia support they get, right? What you can achieve and whatever. So, if you've done a ton of these, probably doing it under sedation or doing it with less anesthesia as you gain experience, I'm sure like that plays a role. But if you haven't done too many, probably what, and then time to work this out. Any other comments about this? As far as I know. Okay. Anything else? Does anybody have any other cases to show? Let's see, we're at 9:30. Does anybody have anything? Please show it. All right. If not, I think what we can do is, I don't know if you wanted to, like, maybe we can take a tiny bit of time. Again, I think probably the audience here, I'm not sure how applicable it is to the audience here, but we are recording this. And so in terms of just like prepared something for the incoming fellows in terms of like, we're working on some basic angiography technique guides. And so I wanted to just show something here and ask for more to just ask for people's suggestions to see what else they might feel should go into this page as far as guidance for how to do in geography. So let me, if you guys want to stick around for a little bit, I just wanted to review something here and see how people feel about this. Hold on a second. So let me just move here. I think, I don't know if you can see this page. It's more of like, there's so many ways to do this, but I think I just, ultimately, like, this is probably like, that's why I feel so like uncertain about it, is because a lot of it is like just how we do it, and it's not in any way like say that like everyone should do this or no one should do this or whatever. But I think that the topic that we want to highlight is the topic of like, that goes into our fellowship a lot, and that's the topic of how to produce a good angiogram. And again, like for the audience here, it's more like a question of what else should be like highlighting this at all. I don't know. But basically, like it's a page like this. Like you have, this is the same page. You have angiogram A on the left, and you have angiogram B on the right. And obviously, you see the difference. There's like a lot of difference in all kinds of technique. And I think that we should be like, part of what our educational mission is to highlight how do you produce the image on the right instead of the image on the left. Just like a surgeon, like a lot of residencies dedicated to teaching residents meticulous surgical technique, and how that translates into better surgeries and you know, complicated way to better outcomes. But I'm not sure how much emphasis we have on this angiographically when you know, in the various fellowships that we've come across or the angiograms that we review. And so this is just more like a pictures of like about how to do this positioning, like emphasizing that the head can be straightened, doesn't have to be crooked. There are ways to straighten the head, and not really like a safety concern or anything, but it just makes for a better picture. So head tilts. Pixel shifting is another one of these things. A lot of it has to do with, of course, movement. None of these pictures are stroke. It's not like we're dealing with a stroke kind of patient where it's a movement situation. These are just diagnostic angiograms. You know, we emphasize like pixel shifting and imaging, but we image our own cases. So the more you image your own case, the more better you get at this. Another one, this is something I learned from Kim Nelson, is like he's very particular about this setup where there's air outside the head. And I think people do it differently. Some people just want to see the whole head. And the disadvantage of that, especially in carotid injection, is that these pixels are not really useful. The information outside the head, there's nothing. There's obviously no vessels there, especially in the other side. And we're not using the whole detector for information. Like that on the right.
Max, your microphone is not, I don't know, sometimes the audio is missing.
Really? This must be some kind of connection problem. Can you hear this now?
No, we can hear you. It's just that a few words don't come out.
Okay, I'm sorry. I'll try to hold it here. Maybe that's the difference.
Maybe this is better, yes.
I don't know. Another one of our things.
Yeah,
like,
this is better.
I don't want to be too like OCD about it either, but there's often so many wires, like all kinds of stuff that wires do. Again, like it's not their safety concern, but we prefer not to have them, and there's a way to do this. So, you know, this is like some pictures that we made of like showing all this, whatever, all this stuff, like tube over the lateral, and this is how we do it. You know, whatever. There's like a co-bands that's kind of holding the head still a little bit. And the leads are running this way. So anyway, so this is like some information to have. Again, so this, for the you know, it's more like for the thing. The other thing that we should probably be talking about, and I think it's less relevant these days because the doses are getting smaller and smaller on our machines, but I think there's not enough emphasis being placed on understanding like what the different settings are in our machines, like a DSA, what the frame rate is, and what it could be. So again, this is not like to say that anyone should be doing, you do whatever you're comfortable with and this and that, goes without saying. But in general, like some people run their angios, or there's like machines set up at 4 frames per second for DSA. And that's probably a little bit on the high side because I don't know if we need such a rate. But this is like an injection of this person like this, 4 frames. There's a follow-up angiogram, 2 frames. There's plenty of information in 2 frames per second. That if there's any concern, if you think there's a shunt or whatever, just switch to 3 or 4 frames, work it out, and go back to 2. And I think it saves a lot of radiation. It's not twice as much, like 4 frames is not twice the 2, because of how the machines are most of the time, but it's obviously 2 is less than 4. And then there's some stuff on technique, like injecting all the vessels. So this is a little bit more like whatever, you can go through this. But sometimes, I mean, the examples here is to show how this actually impacts diagnosis. This is a spinal angiogram done. You know, there's all kinds of problems with this angiogram. The patient's not under GA. There's like positioning. There's all kinds of movements here. And so in the end, like this particular patient has 2 spinal angiograms for something that looks like this. Obviously a shunt of some sort going on in this person. And there are 2 spinal angiograms, and both of them lead to no diagnosis. Look at this. There's like a nice MRI that's obtained. It's a very interesting case. The whole case is on the website too, because it turns out, like, look at this, look at all this congestion. It's crazy. And so anyway, so there's a second angiogram, and the bottom line is that when you do the angiogram properly, like it takes 10 minutes and you find the shut. And so it turns out it's a very interesting case because it turned out to be a PO fistula, not a dural fistula. But because of, it's a long-standing PO fistula, and in the end, what happened to this patient is the original PO fistula outflow became compromised, was occluded. It's probably like a high flow venopathy. And so what happens is the original outflow is compromised, and so the secondary outflow is into these congested spinal veins. And so it's a PO fistula that actually presents like a dural fistula with venous congestion. But the seat of disease, the problem is not at the nerve of sleep. The problem is actually very interesting case was cured with a combined surgical, like basically an angiogram and a surgical connection. So anyway, again, more like whatever, this is more just our kind of like guide page for those that are interested. You have any suggestions about this? Like, should we even, is it too dogmatic? Is it too like prescriptive? Should we be showing more of this? What else we should concentrate on? Maybe let us know. You could email us. You know, we're happy to like hear suggestions or criticisms or whatever. Okay. Anything, any feedback, anything else? All right. Okay, cool. Okay, so I think we'll end a little bit early here since definitely places we need to run to. So I want to thank everybody for coming. Again, thanks for participating. And we're planning to, again, we're going to once per month. So we're going to, the next session is going to be August, whatever, the first Tuesday in August. August 4th. And we'll send out, we'll put up a program on the BANANAZ page, and we'll email you through the newsletter about program, what we're still like working out what the program might be. But the plan is to continue forward and do this like in a monthly fashion for until whatever. So there's no end date yet. So we'll go with that. Okay. Because Gilberto, thank you. Thank you. Anything else? Let us know. And again, like feedback, if you want to present, you got anything? Let's do that. Sure. Okay. Thanks so much, and we'll see you in a month.
Thank you.